Hello, my name is Robert Renkin, and this is my presentation on short and long-term effects of exercise in early childhood on bone mass density. Osteoporosis is one of the biggest issues Americans face today in aging populations, sedentary populations, and many other groups of Americans. This presentation focuses on the effects of exercise programs on bone mass density in children. Programs mostly consisted of moderate to high intensity jumping exercises added into regular physical education curriculum. Programs lasted from about 7 months to 3 years. I'll also be looking at short and long-term effects on bone mass density. Ages focused on in this study will range from prepubescents to adolescents to young adults. I'll also be looking at overall bone mass change, growth, or loss, as well as site-specific bone density changes. When looking at total body bone mass density, boys between 4th and 6th grade showed an increase in bone mass density in intervention groups when compared to a control group. The intervention group added 2 bouts of weight-bearing, high-impact exercises per week into regular physical education programs. These exercises included various jumping exercises that increased in intensity throughout the school year. Both groups increased their total body bone mineral content. However, the intervention group showed a larger procurement of total body bone mineral content. The intervention group showed about a 9.8% increase, and the control group showed about an 8.2% increase. Other studies have also shown similar results. One review study showed an average 0.8% higher increase in total body mineral content in intervention groups compared to control groups. Another study showed periosteal and endosteal surfaces also increased by around 2.6 and 2.7% higher than control groups, respectively. This led to about a 7.5% greater increase in section modulus, or bone bending strength. One study I found followed schools with the Action Schools BC curriculum for 16 months. Total body increase in bone mineral content was found to be about 1.7% higher than control, as well as the lumbar spine showed an average increase in bone mineral content by 2.7% larger than control. One jumping program I found showed a large difference between intervention and control groups on top of that. This jumping program consisted of 25 jumps per day off of a 45 centimeter box, 5 days per week for 12 weeks. This study found total bone mineral content in the intervention group increased by average 45 grams of bone mass. Control group had an increase by an average 29 grams of bone mass. This shows that adding in weight-bearing, moderate to high intensity exercise, even as low as 2 days a week on top of regular physical activity, can be beneficial for bone mass density. Bone mass density over time. One study did a 20-month follow-up on girls at the time ages between 10 and 14 that were put through a 9-month jumping program. This study looked at various points, including the femur and lumbar spine. The lumbar spine showed an increase in bone mineral content by 28% in the intervention group, while the control group showed a 22% increase. The proximal femur showed a higher bone mineral content procurement in the intervention group as well, but was not statistically significant. Another study looked at a 3-year follow-up of a 9-month jumping exercise program that consisted of 1st and 5th graders that included daily high-impacting activities. On DEXA scans, total body, femoral neck, and total hip z-scores of bone mineral content was 0.157, 0.205, and 0.195 units larger than control groups, respectively. And higher z-scores for areal bone mineral density that represent a 6 to 8% higher value in the intervention groups. Another study that I've found showed peak strain at ages 11 and 15 were found, specifically in boys, to be positively associated with bone mineral density procurement when the subject was 18. The largest effect on bone mineral density at 18 came at 15 with high peak strain and increased physical activity. For females, highest bone mineral density procurement at 18 was found with impact physical activity at 11 years old, slightly younger. This shows that high impact activities integrated into physical education has immediate and long-term effects on children and their growing bone mass density. While total body bone mineral content and bone mass density is increased, there seems to be a site-specific increase with these as well. In the same study that showed a 0.8% increase in total body bone mineral content, there were greater increases seen in the lumbar spine and femoral neck. The lumbar spine increased by about 1.7% greater than control in intervention groups, while the femoral neck increased 1.5% greater in intervention groups. Another meta-analysis showed that bone mineral content and areal bone mineral density at the lumbar spine and the femoral neck increased with weight-bearing exercises. In this study, lumbar spine bone mineral content and areal bone mineral density increased by an effect size value of 0.19 and 0.26 respectively. With these same effect size values, the femoral neck bone mineral content increased by 0.23. This graph is a basic graph showing two separate groups. The black bar represents jumping groups, while the white bar represents control groups. The black bars clearly show a greater percent change in bone mineral content. One study showed, after 7 months in a study in prepubescent children, femoral neck bone mineral content and bone area showed significantly greater changes than a control group. The intervention bone mineral content was increased by 0.15 versus 0.066 in control groups, and the intervention bone area was increased by 0.161 versus 0.083, almost double the increase in area. Bone mineral density increases were found to be similar for both groups. In the femoral bone mineral content and bone area increases amongst the intervention groups, the lumbar spine, however, had greater bone mineral content and bone mass density. Bone mineral content increased by 1.956 versus the control group increase of 1.26. And the bone mass density increased by 0.021 versus the control group increase of 0.010. There was no significant difference between lumbar bone area between intervention and control groups. Similar results were shown in another study that looked at increasing physical activity time per day. Intervention groups exercised for about 200 minutes per day, while control groups exercised for the regular 60 minutes per day. In this study, female average gain in lumbar bone mineral content and vertebral width were 0.9 standard deviations and 0.4 standard deviations higher in the intervention groups compared to the control groups, respectively. For females, femoral neck bone mineral content and bone area, these were both higher in intervention groups compared to control groups, 0.5 standard deviations higher for both. In males, lumbar bone mineral content and vertebra width were 0.8 standard deviations and 0.3 standard deviations higher than the control groups that were looked at, respectively. This study broke their physical activity into levels. On each level increase, there was a dose-response relationship between each higher tertile and the procurement of bone mineral content in both boys and girls. Site specificity can also be seen in the long term. As looked at earlier, lumbar spine and femoral neck bone mass density at 18 was positively associated with impact physical activity at ages 11 and 15. For boys, 15 had a larger effect on bone mass density at the femoral neck, but not as great at the lumbar spine. For girls, age 11 had a larger effect on both points for bone mass density. This is similar to source 10. They found the greatest increase in lumbar and femoral bone came during the pubertal stages of growth. When looking at fracture risk, reference 1 asserts that an increase in bone mineral content is in fact vital, but the increase in bone cross-sectional area is the most important factor in bone strength. This means that increasing your bone mineral content and bone area will give you a stronger and larger bone that will be less likely to fracture. However, the higher intensity of physical activity, the risk of fractures go up. This in general has to do with exposure to trauma. Even though bone mineral density is increased and the bone is stronger and larger, the person is increasing their risk of trauma. This equalizes the fracture risk. However, no fracture risk was reduced by more than 29% or increased by 62%, which is within 1 standard deviation. My recommendations are that all schools, private or public, should integrate extra physical activity into their regular physical education programs between kindergarten and high school. Some gains in bone mass density can be seen as early as elementary school age. However, most gains are seen in bone mass density between ages 9 and 15, depending on gender. There's also been found a dose-response relationship between exercise and bone mass density. Exercise programs should be over an hour and preferably with moderate to high intensity weight-bearing exercise. Jumping is a simple and efficient way to integrate these exercises, as well as an easy exercise to change and tailor depending on person, intensity, and exercise experience. This is because exercise programs build the most bone mass density in the femur, hip region, and lumbar spine. All of these areas are weight-bearing areas for humans and are problem areas for osteoporosis. And with decreased instances of osteoporosis, there can be decreased numbers of full hip or knee replacement surgeries, decreased back pain, and less overall negative effects from sedentary behavior. Thank you for listening to my presentation, and have a happy holidays.